Hello everyone, so today we'll speak about juvenile idiopathic arthritis. So it's a broad term for a childhood rheumatic disease that begins before the age of 16, and they are characterized by joint inflammation that lasts more than 6 weeks. So it's classified into various types based on the pattern of joint involvement, the presence of extra articular manifestation like uveitis, rash, nail changes, lymphadenopathy, hepatosplenomegaly. So, oligoarticular juvenile idiopathic arthritis is the most common type, present with asymmetric involvement of up to 4 joints, with the knee joint must often be affected. So, nearly half of the cases of oligoarticular JIA are associated with anterior uveitis, which may be diagnosed by slit lamp examination. So, the lab tests are such as ESR, rheumatoid factor, anti-nuclear antibodies, and the HLA B27 antigen tests are used to classify and determine the prognosis of juvenile idiopathic arthritis. And we'll speak about the treatment later, to be honest. Just this overview summary about the topic and the things that we'll cover today. So for the epidemiology, the prevalence is 1 to 1,000 child. It affects the females more than the males, and the age onset is less than 16 years, as we mentioned earlier. So the etiology, we said idiopathic. That means we don't know the source of the cause. Immunological predisposition, different HLA associations depending on the type. Like for example, in the oligoarticular JIA, HLA DR8 and DR5 are present. Polyarticular HLA DR4 and anaphysis associated and psoriatic juvenile idiopathic arthritis, we will have HLA B27. And it's possible triggered by a viral or bacterial infections, and exposure to antibiotics during childhood may increase the risk of it. So for the pathophysiology, autoimmune and or autoinflammatory disease will lead to chronic synovial inflammation with infiltration of plasma cells, B lymphocytes and T lymphocytes. That will lead to joint capsule hypoplasia, and we'll have a growth of fibrovascular connective tissue and the invasion of the articular surface, and this will lead eventually to loss of the joint function. This is the pathophysiology. The clinical features, so we will have first of all arthritic symptoms, like we will have swollen joints, maybe sometimes arrhythmia, early morning stiffness, limited or painful joint movement. Then we have extra articular manifestation, so which is symptoms outside the joints. So we'll have fever for more than 2 weeks, uveitis, which is the inflammation of the middle eye, rash, nail changes, lymphadenopathy, and hepatosplenomegaly. So in this picture, we will see the uveitis, the inflammation of the middle eye. Let's speak now about the subtypes and the variants. So first of all, we speak about oligoarticular juvenile idiopathic arthritis. It's the most common type. It accounts for 50% for all the cases. We will have arthritis involving less than or 4 joints within 6 months of the disease onset. We have a symmetrical pattern, so we might have it on the right side but not the left side. We have large weight-bearing joints that will get affected, like the knee and the ankle are affected. We will have a chronic anterior uveitis. For the labs, we have a high ESR, negative rheumatoid factor, positive anti-nuclear ANA, which is, let me just remember, I forgot it to be honest. It is anti-nuclear antibody, sorry. And for the treatment, we use NSAIDs and possibly intra-articular steroids injections, and possibly methotrexate, which is DMARS. Then we'll have seronegative polyarthritis. It's about 30% of the cases. We have arthritis involving more than 5 joints within 6 months of the onset of disease. It could be symmetrical or asymmetrical. We'll have involvement of the cervical spine and temporomandibular joints are also affected. We have also a chronic anterior uveitis. ESR will be high this time. And here we have also negative RA. So we have negative RA as well and positive anti-nuclear antibodies in 40% of the cases. And the standard therapy with it is methotrexate and NSAIDs. So for the labs, actually, it's the same. Then we will have seropositive, this is seronegative, seropositive polyarthritis. It's less than 10% of the cases. Arthritis will involve more than 5 joints within 6 months. This time it's symmetrical. Rheumatoid nodules will be seen on the extensor surface of the elbow and the Achilles tendon. ESR will be high and positive rheumatoid factor finally. And the treatment is methotrexate and NSAIDs. So we all know what this is. This is the rheumatoid nodule. We see it on the extensor surface of the elbow. So here's a recap. The oligoarthritis, it affects 2 to 4 years of age. Females more, all of them are females more than males. We see affecting of 4 or less joints. It is asymmetrical, and we can see uveitis. Seronegative, we see the involvement of the cervical area and the temporomandibular joint, affected more than 6 joints and uveitis. And seronegative, 7 to 10 years of old. And 9 to 12, we will have seropositive polyarthritis with the affecting of more than 5 joints, but not the cervical or the temporomandibular joint. Then we have psoriatic juvenile idiopathic arthritis. It's about also less than 10% of the cases. We will have this time arthritis and psoriasis. Arthritis aren't more than 2 of the following features: dactylitis, nail changes, pitting nails or ankylolysis. We spoke about them in the nail changes episode. We say pitted nails and ankylolysis will appear in psoriatic patients. So check them out if we didn't see it. And psoriasis among the first 3 relative, like history of psoriasis. It was asymmetrical. You'll have chronic anterior uveitis as well, nail changes, psoriatic skin lesion, NAA, anti-nuclear antibody will be positive in 50% of the cases, but the specific one is HLA-B27 will be positive. Rheumatoid factor is negative. The treatment will be NSAIDs and intra-articular steroids. So this is dactylitis. We will see a swelling digits. Look at the difference between those digits. It's called usually the sausage fingers, I think. So now we will go to enthesitis related juvenile idiopathic arthritis. So here we will have arthritis with enthesitis, which is the point at which the tendon attached to the bone will be inflamed. So it's asymmetrical. We will have acute anterior uveitis again, and we will have associated with chronic inflammatory bowel disease. I may progress to ankylosing spondylitis. We will see bumbo spine here. I forget to take a picture. Then we will have HLA-B27 will be positive, like in psoriatic. RF will be negative. NSAIDs and intra-articular steroids will be treatment. We can use methotrexate or sulfazenazine, which are both DMARDs, as a treatment as well. So this is enthesitis. As we can see, there is inflammation in the points of the attachment of the tendon. So we already spoke about those. We don't need to repeat them again, but maybe stop the picture photo and look at them, especially the ages. I didn't mention them. Then we will have systemic juvenile idiopathic arthritis, which is also called as still disease. So arthritis involving more than one joint and intermittent fever that lasts for at least 2 weeks, with fever spikes occurring on at least 3 consecutive days and more than one extra articular menstruation. So you should have a problem with the joints, fever, and we will also have one extra articular menstruation to diagnose stall disease. So it can occur as monoarthritis, oligoarthritis, or polyarthritis, and it often involves the knees, ankles, and the wrists. Transient migratory macular salmon pink rash will be seen in this condition with or hepatomegaly, lymphadenopathy, and some conditions like pleuritis, pericarditis. So for the labs, ESR will be high, acute phase reactants will be high like CRP and ferritin. Anemia, leukocytosis, and thrombocytosis will be seen. RF will be negative. NSAIDs and NSAIDs will be the treatment, and there's a poor response to methotrexate and TNF inhibitors, which are biologic DMARDs. So this is the salmon-like skin rash, as we can see. Like the points things, it's like it. We spoke about this. We don't need to read it again. For the diagnosis, as we mentioned, we will do labs just to differentiate between the different types. So we'll see the autoantibodies levels, rheumatoid factor, if it's positive or negative, absent. In most, this is some explanation about the results that we will get. So it's absent in the most cases of juvenile idiopathic arthritis, except the seropositive polyarticular arthritis, and this is associated with poor prognosis. ANA will be positive in oligoarticular juvenile arthritis. Incidence of anterior uveitis increase when ANA are present, and this could lead to blindness, by the way. Anti-CCP antibodies indicate a poor prognosis as well. Acute phase reactants, ESR and CRP will be high. ESR in all forms, CRP and ferritin with systemic one. Anemia, leukocytosis, and thrombocytosis will be also seen in polyarticular and systemic juvenile idiopathic arthritis. So for the imaging, we will do ultrasound to detect the synovial hypertrophy and intraarticular fluid collectance. This is not. And yes, basic imaging tools for detection for early bone erosions. X-ray will see for the complications, and we will perform it routinely to see how the condition is developing. So other diagnostic tests, we will do slit lamp examination. This is used to diagnose the anterior uveitis and see the patients with them and see how they're progressing. Let's see a video of it. As you can see, it's red. Look how red it is. And we also see changes the pupil, but just look at the redness. Such an amazing video, to be honest. Let's get back. And yes, so this is the slit lamp examination. So this is like the instrument. And this is the normal results we see. Look, the pupil is normal. There's no redness in the sclera. And look, the pupil is like, if they call it the flower-shaped pupil. And look at the redness in the sclera. The treatment. So first line of therapy is NSAIDs. It's used for the it's like highly effective in the treatment of it, and we can use local intra-articular steroids. It's indicated in some cases of active arthritis. Second line of treatment, we will use DMARDs like methotrexate. We should start it as early as possible. We could also use some biologic agents like each one of those are a certain inflammatory cells inhibitor. We can also do systemic glucocorticoid therapy, oral IV, but it's rarely used in children because it has some risk of catabolic side effects like osteoporosis or growth impairment. And for some severe involvement, like if we have still disease, we could need. I forget where I wrote it. I don't have energy, but sometimes we need some surgical like involvement because in still disease we won't have normal shaped bones. I will do a supportive therapy. This is it. Surgery, supplements, or to correct limb length in some and joint deformities in some conditions like still disease, and physiotherapy. That's actually everything, to be honest. This time the lecture wasn't that short. Thank you so much for watching. I hope you found this lecture useful. You liked it. You found it useful. Thank you so much for watching, and have a great day. Goodbye.